Welcome to the Hospital Medicine Unplugged podcast. Today we're tackling a really challenging topic, one of those syndromes that tests us every day, fever of unknown origin, FUO. But we're specifically zeroing in on the hospitalized patient, the nosocomial setting. We want to go beyond just the definition and really dig into a modern, evidence-based way to approach this.
Yeah, this is so important for anyone on the wards or in the ICU. Our goal here, really, is to pull together the current guidelines. Thinking about IDSA, SCCM, and recent reviews, we want to give you a systematic framework, something clue-driven, because it's not just about getting a diagnosis. It's about maximizing that diagnostic yield smartly. And, maybe most importantly, having the discipline to avoid unnecessary tests or treatments that just muddy the waters.
I think that's the toughest part, right? Resisting that urge, especially when a patient's been febrile for days, to just order everything or try empiric antibiotics. We have to remember, and this is key, most FUO cases, especially nosocomial ones, they're usually common things presenting weirdly.
Exactly. They're not usually the zebras. The minute you start thinking about, some incredibly rare vasculitis you read about once, you might be missing the infected central line right under your nose.
Or the DVT. Or just a simple drug reaction.
Precisely. Find the common things presenting uncommonly. That's the mantra.
Okay, so let's start with definitions, because classic FUO is different from what we deal with day to day in the hospital. The original definition goes way back, doesn't it? Petersdorf and Beeson, 1961.
That's the one, the historical standard. They defined it as a temperature of 38.3 Celsius, so 101 Fahrenheit, on several occasions, and persisting for at least 3 weeks, with no diagnosis after a full week of inpatient investigation.
But like you said, things have changed. 3 weeks, a full week inpatient just for the workup. That doesn't really fit modern medicine or diagnostics.
Not at all. The consensus now leans towards something more qualitative. It's about a reasonable diagnostic evaluation, failing to find the cause. Forget the strict timelines. If you've done a thorough workup over maybe 3 outpatient visits, or importantly for us, 3 days in the hospital, and you're still scratching your head.
And as you can call it FUO, it's about the intensity and structure of the workup, not just the clock.
Exactly. And that shift is important. But for hospitalists, the critical distinction is nosocomial FUO. This has a very specific definition that changes everything. It's a fever that starts after 48 hours of being in the hospital.
Meaning it's hospital acquired?
Right. And there's no obvious source initially, and it persists even after a focused sort of initial 3-day workup doesn't give you an answer.
And defining it that way, nosocomial immediately points you towards a different set of potential causes, right?
Completely different. Classic FUO might make you think about chronic infections like TB or maybe some slow-burning autoimmune disease. But nosocomial FUO, you're thinking about complications from procedures, lines, devices.
Yeah.
You're thinking hospital bugs. You're thinking about the drugs we just started.
It's all about the hospital context. Makes sense.
Which is why that systematic approach, starting with that context, is just so vital.
Okay, so let's map out that nosocomial differential. What are the big buckets based on, the studies looking at prevalence?
Generally, you can break it down like this. Infections are still the most common, maybe 30 to 40% of cases. Malignancy is next, maybe 20 to 30%, though often a bit less acute. Then you have the non-infectious inflammatory diseases, NIIDs, around 10 to 20%. Miscellaneous causes, a smaller slice, 5 to 10%, but important. And then there's always that 10 to 15% that remain undiagnosed.
And interestingly, those undiagnosed ones often do okay long-term.
Often, yes, which reinforces the need for careful, not frantic investigation.
Let's spend some real time on that biggest chunk, the nosocomial infections, 30 to 40%. This is where we often find the answer. Where do we look first in the hospital setting?
Hardware. Always start with the hardware. Catheter-associated infections are huge. Central lines, PICCs, dialysis catheters, even temporary pacing wires or surgical drains. And it's not enough just to see a positive blood culture. If there's a central line, you need paired cultures.
Central and peripheral, drawn at the same time.
Exactly. And you look at the differential time to positivity. If that central line culture flags positive 2 hours or more before the peripheral one, bingo, that's your source.
Gold standard for a line infection. And you're usually thinking staph.
Staph or Niesis, coag-negative staph, sometimes gram-negatives or candida, especially if they've been on broad-spectrum antibiotics.
And knowing it's the line tells you it has to come out versus just treating through it.
Critical management decision right there. Beyond lines, what else?
Occult UTIs are definitely up there, especially in catheterized patients or those with neurogenic bladder.
The tricky part is telling infection from colonization. If they have a chronic Foley, they will have bacteria. You need more pyuria, systemic signs, maybe flank pain.
Funguria, too, often just colonization unless the patient is neutropenic or has had urologic surgery.
Right. And think about the lungs. Ventilator-associated pneumonia, sure, but also just hospital-acquired pneumonia or aspiration, especially in patients with altered mental status or swallowing issues. Sometimes a chest x-ray is surprisingly clear initially. Fever might be the first sign.
And sinusitis, that one gets missed a lot, especially with NG tubes or nasal intubation.
Oh, frequently. Patients can't complain of facial pain if they're sedated. You have to have a high index of suspicion.
What about deeper sources? Abdomen, pelvis?
Absolutely critical, especially post-op, intra-abdominal or pelvic abscesses. If a fever spikes 7, 10, 14 days after GI surgery, GYN surgery, even thoracic surgery.
You need imaging. Even if the abdominal exam isn't dramatically positive.
Low threshold for a CT scan in that context. Don't forget things like C. diff colitis, which obviously causes fever. And then, less common, but still on a list, endocarditis, especially if there's a new murmur or risk factors like IV drug use or prosthetic valves. Also, opportunistic infections in the immunocompromised CMV, fungal infections, maybe TB reactivation.
Okay, let's shift gears to the second biggest category, malignancies, 20 to 30%. How do these typically show up as a nosocomial FUO? They're usually more chronic processes.
True, but sometimes the fever is the first thing that brings the underlying cancer to light or represents a complication. Lymphoma is the classic one, Hodgkin and non-Hodgkin. There's that rare but famous Pell-Epstein fever pattern, days of high fever, then days of remission, classically linked to Hodgkin's, though not specific.
More often, it's just persistent unexplained fever, maybe with night sweats, weight loss, if you can get the history.
Exactly. Leukemia can also present with fever due to the disease itself, or secondary infections from neutropenia. Renal cell carcinoma is notorious for causing paraneoplastic fever, and metastatic solid tumors, especially with liver mets.
Why the liver specifically?
Tumor necrosis, or just the sheer bulk of metabolically active tumor tissue in the liver, can trigger a huge cytokine release, driving the fever.
Got it. Now, the non-infectious inflammatory diseases, the NIIDs, 10–20%, these can really mimic infection.
They absolutely can. Pattern recognition is key here. Adult onset Still's disease is a great example. You're looking for that very specific fever pattern. Huge spikes, once or twice a day, often hitting 40 Celsius, maybe even higher.
But crucially, the temperature comes all the way back down to normal or even subnormal between the spikes. Quotidian fever.
Precisely, and often accompanied by that classic evanescent salmon-colored rash that comes out with the fever, usually on the trunk and proximal limbs. Pharyngitis is common too, arthralgias, and the lab clue.
Ferritin, sky-high ferritin.
Outrageously high. Often over 1,000, sometimes 5,000, 10,000, even higher. That combination, quotidian fever, salmon rash, maybe sore throat, and a massively elevated ferritin screams Still's disease.
Much more likely Still's than typical bacterial sepsis with that pattern. What about vasculitis presenting as FUO in the hospital?
Also important, giant cell arteritis, GCA. In older adults, you must ask about headache, visual changes, jaw claudication. Tenderness over the temporal artery is a huge clue. Polyarteritis nodosa, PAN, can cause fever with things like mononeuritis multiplex, bizarre abdominal pain, or renal infarcts. And of course, flares of known diseases like SLE, rheumatoid arthritis, or sarcoidosis can certainly present primarily with fever. Need to look for other systemic clues.
Okay, last category before we get to the workup, miscellaneous causes, that 5 to 10%. You said high yield. What's top of the list?
Drug fever. Absolutely number one in this bucket, the great mimicker.
How does it work? Why do drugs cause fever?
It's usually a hypersensitivity reaction, often type 4. The drug, or a metabolite, acts like an antigen, triggering immune activation and cytokine release. IL-1, IL-6, TNF-alpha, the usual suspects.
And the key clue is timing.
Timing is critical. It usually starts 1 to 2 weeks after the drug is initiated, though it can be faster or sometimes even delayed. Clinically, you might see relative bradycardia. The pulse isn't as high as you'd expect for the temperature.
The Faggot sign, though not specific.
Right. And labs might be surprisingly normal, maybe just a hint of eosinophils elevation, but often not even that. The rash is inconsistent. The diagnosis is really made by stopping the suspected drug and seeing if the fever resolves, usually within 48 to 72 hours.
Which drugs are the most common culprits?
Classic ones are beta-lactam antibiotics, sulfur drugs, anticonvulsants like phenytoin or carbamazepine. But honestly, almost any drug can cause it. Allopurinol, even things like heparin or H2 blockers have been implicated. You need a meticulous med review.
Beyond drugs, what else is in the miscellaneous bucket?
Thromboembolic events. DVT or PE can definitely cause fever, usually low grade, but not always. Keep it on the differential, especially in immobilized or post-op patients.
And in the ICU or neuro patients?
Neurogenic fever, super important in that population. It's not infection, it's dysfunction of the hypothalamic thermostat, usually after brain injury, stroke, hemorrhage, trauma, neurosurgery. The fever tends to be high, sustained, and notably resistant to standard antipyretics like acetaminophen or NSAIDs. That lack of response is a clue.
Makes sense. Anything else?
Less common things like thyroiditis, check a TSH, resolving hematomas can cause low-grade fever, and rarely factitious fever, though that's a diagnosis of exclusion.
So it's a wide range: infection, cancer, inflammation, drugs, clots, brain injury. But you mentioned they all funnel down to the same mechanism.
Fundamentally, yes. Whether it's bacterial endotoxin, tumor necrosis factor from a malignancy, or cytokines from an autoimmune reaction, they all stimulate the release of endogenous pyrogens, IL-1, IL-6, TNF-alpha primarily. These act on the hypothalamus, raise the thermoregulatory set point, and boom, fever. Understanding that helps explain why ESR and CRP are useful nonspecific markers for almost all these categories.
Okay, let's pivot to the practical approach. The patient meets criteria for nosocomial FUO. What are the steps in the initial 48 hours? Step 1, make sure it's real.
Sounds basic but essential. Confirm true fever, at least 38.3 C or 101S on at least 2 occasions. And use a reliable method. Oral's okay if the patient is stable, but if they're tachypnea, hypotensive, or you have doubts, you need core temperature rectal, bladder probe, esophageal PA catheter.
Avoid axillary or temporal scanner temps for defining FUO.
Absolutely unreliable for this purpose. And consider factitious fever if things don't add up, like a sky-high temp in a patient who looks completely well, or major discrepancies between different measurement sites. But that's rare.
Okay, fever confirmed. Step 2, the history. You called it the clue hunt.
And it needs to be meticulous. Focus on the last few weeks especially. Every procedure, every surgery, every line, every drain, when was it placed, any issues. The medication review needs the same detail, not just what they're on now, but what did they start recently? What stopped recently? Any changes in immunosuppression like steroids tapering?
Even seemingly benign changes.
You bet. And don't forget epidemiology, even in the hospital, any recent travel before admission, sick contacts, underlying conditions like diabetes, HIV, cirrhosis, any specific exposures.
This helps tailor downstream testing, like serologies for specific bugs based on risks.
Exactly. Maybe you need CMV or EBV testing in an immunocompromised host, or Q fever serology if there was livestock exposure before admission.
Step 3, the physical exam, but not just once, serial exams.
Critical point. The exam findings in FUO can evolve day by day. That subtle rash today could be purpura fulminans tomorrow. The faint murmur might become a roaring regurgitant murmur. You have to do a thorough head-to-toe exam every day. Pay special attention to skin rashes, nodules, petechiae, track marks, eschers, eyes, conjunctivitis, uveitis, mouth ulcers, thrush, lymph nodes, heart new murmurs, lungs, abdomen tenderness, organomegaly, joints. And meticulously examine every line site, surgical wound, pressure ulcer. Look for meningismus. Check for DVT signs, even if low yield like Homans. In older adults, palpate those temporal arteries.
While we're doing this intense clinical assessment, we start the baseline lab workup, the minimum set for every FUO patient.
Right, the non-negotiable basics. Complete blood count with differential looking for leukocytosis, left shift, maybe eosinophilia for drug fever, or cytopenias suggesting malignancy or marrow suppression, basic metabolic panel, liver enzymes, ALT, AST, alkaline phosphatase, bilirubin. LDH can be a marker for hemolysis or tumor lysis. CK if muscle pain or rhabdo is suspected. Urinalysis and urine culture are essential.
Just X-ray standard.
Yes, baseline chest X-ray for everyone with nosocomial FUO, especially in the ICU. Occult pneumonia is common.
And the cornerstone, cultures.
Absolutely. At least 2 sets of blood cultures from separate peripheral sites. And again, the crucial point from IDS, ASCCM. If a central line is present, you must draw simultaneous central and peripheral sets.
Looking for that differential time to positivity.
Precisely. If it's 2 hours, you've likely found your source, pull the line.
And we also need to get those baseline inflammatory markers.
Yes. ESR and CRP. While non-specific, they tell you the degree of inflammation. A very high ESR, say over 100, generally points towards something significant. Deep infection, vasculitis, malignancy. It makes benign, self-limited causes less likely. We also do baseline rheumatoid factor, RF, and anti-nuclear antibodies, ANA, as initial rheumatologic screens. plus HIV testing if status is unknown.
What about broad imaging at this stage? Beyond the chest x-ray, should we just CT everything?
No. Restraint is key here. Avoid the pan scan unless there are specific clues. Abdominal pelvic imaging ultrasound or CT should only be done initially if there are localizing signs or symptoms. Abdominal pain, tenderness, significantly abnormal LFTs. The one exception is recent thoracic, abdominal, or pelvic surgery. In that case, CT of the relevant area is reasonable even without localizing signs, looking for post-op collections. Otherwise, hold off on broad TTs initially.
Because the yield is low without clues, and the risk of false positives and incidentalomas is high.
Exactly. You end up chasing shadows, doing more tests, delaying the real diagnosis.
Okay, so we've done the initial 48, 72 hours. History, serial exams, baseline labs, limited imaging. If we still don't have an answer, we shift gears.
Now we move from screening to CLE-directed investigation.
If infection still seems likely, what's the next step?
Repeat cultures, especially if the fever pattern changed or new lines were placed. Maybe consider special cultures if you suspect something specific, like fungal or AFB cultures. If standard cultures remain negative after a week or so, especially with high fevers or signs suggestive of endocarditis, you start thinking about culture-negative endocarditis or unusual bugs. This is where infectious disease consultation is crucial.
And targeted imaging now becomes more appropriate based on subtle clues or risk factors.
Right. If the LFTs are still climbing, maybe now you get that formal abdominal ultrasound or triple-phase liver CT looking for an abscess or cholangitis. If they had that recent surgery, even if the initial look was negative, if they're still febrile, you might repeat the CT of the surgical bed.
What about these newer molecular diagnostics? When do they come into play?
They can be really helpful for those tough cases, especially in immunocompromised patients or when you suspect culture-negative infection. Things like broad-range 16S RNA PCR can detect bacterial DNA even if the bug won't grow. Multiplex PCR panels for blood or CSF can identify common pathogens quickly, and next-generation sequencing NGS on tissue or fluid samples can sometimes find really obscure organisms. But these are specialized tests, usually ordered and interpreted with ID help.
So let's say we've pursued the infectious angle, maybe done some targeted imaging, but we're still stuck. And importantly, the inflammatory markers, ESR and CRP, are still significantly elevated. What's the next big diagnostic step?
This is where FDG-PTCT really shines. 18F-fluorodeoxyglucose PTT combined with CT.
This has become a major tool in FUO workup, hasn't it?
Absolutely. The current thinking, supported by evidence, is that PTCT is the nuclear medicine test of choice when ESR-CRP are up, and your standard imaging X-ray, ultrasound, maybe targeted CT, hasn't found the source.
Why is it better than just a regular CT scan in this situation?
Because it shows metabolic activity. The FDG tracer is taken up by cells that are using a lot of glucose, which includes activated immune cells in areas of infection or inflammation, and rapidly dividing cancer cells. So it lights up hotspots disease activity anywhere in the body, even if there's no obvious structural abnormality on the CT part yet.
What kind of diagnostic yield are we talking about?
It's quite high. Studies show sensitivity around 85–90% for finding the cause of FUO in this selected population. It contributes to the final diagnosis in roughly 75% of cases where it identifies a focal source. It's particularly good, better than CT alone, for finding occult lymphomas, other neoplasms, or areas of vasculitis or deep infection.
And what if the PET-CT is completely negative? Is that useful?
Very useful. A negative PET-CT in a patient with FUO and high inflammatory markers makes a focal infectious, inflammatory, or malignant process much less likely. It provides significant reassurance and allows you to pivot your thinking towards maybe non-focal causes, like drug fever, or maybe those NIIDs like Stilsat might not show a specific hotspot, or even neurogenic fever.
That sounds powerful, but PET-CT isn't available everywhere, and it's expensive. Are there downsides or limitations we need to consider? False positives.
Definitely. Availability and cost are real-world issues. And yes, false positives happen. PTT is very sensitive to any inflammation. Recent surgical sites will light up, areas of arthritis will light up, healing, fractures. Known infections you're already treating. You have to interpret the findings in the clinical context. A hot lymph node in the neck might be reactive, while a chain of hypermetabolic nodes in the retroperitoneum is much more concerning.
So if the PET-CT, or maybe a targeted CT, does show a suspicious focal lesion, a lymph node, a liver lesion, abnormal bone marrow uptake, what's the next step?
Tissue is the issue. Biopsy becomes a priority. If imaging points to a specific, accessible target that could explain the FUO, you need to sample it. Lymph node biopsy, liver biopsy, maybe biopsy of an involved skin lesion. And we specifically consider bone marrow biopsy if there are unexplained cytopenias, anemia, low white cells, low platelets, or if lymphoma or leukemia remains high on the differential, even if the PUT wasn't strikingly positive in the marrow.
Makes sense. Get the tissue diagnosis. Before we talk management philosophy, let's quickly cover those other second-line checks we might do if things are still unclear.
Right. Don't forget the miscellaneous causes. If drug fever is still suspected, and you identified a likely culprit drug, the definitive test is withdrawal. Stop the drug, wait 48-72 hours. If the fever breaks, you have your answer. If DVT-PE is still a possibility, maybe the patient has tachycardia, maybe a slightly elevated D-dimer, then you proceed with lower extremity Dopplers or a CT pulmonary angiogram. And check thyroid function test TSH, free T4, to rule out thyroiditis if that hasn't been done.
Okay, this leads us to probably the most important and often hardest part of managing FUO, the philosophy around treatment, especially empiric therapy.
This is absolutely critical. The general rule, the default position, should be avoid empiric therapy in undifferentiated FUO.
Why is that restraint so important?
Several reasons. First, empiric antibiotics expose the patient to risk side effects, C. diff, promoting resistance, often for no benefit. Second, empiric steroids or NSAIDs can mask the fever and symptoms of serious infections or malignancies, delaying the correct diagnosis. Third, antibiotics can suppress the growth of fastidious organisms and cultures, making it even harder to figure out what's going on. And honestly, in true undifferentiated FUO, where you don't have strong clues, blind empiric therapy is rarely effective anyway.
But that's tough advice when you have a sick, febrile patient in the hospital, maybe looking worse day by day. Surely there are exceptions.
Yes, absolutely. The no empiric therapy rule is not absolute. It applies to the stable patient undergoing investigation. Empiric treatment is justified and necessary in specific high-risk situations. 1. Severe neutropenia, absolute neutrophil count 500. Febrile neutropenia requires immediate broad-spectrum antibiotics. 2. Known severe immunocompromise, like a recent transplant recipient, or an AIDS patient with a low CD4 count, where opportunistic infections are a high risk. 3. Clinical instability. If the patient is hemodynamically unstable, showing signs of sepsis or septic shock, or rapidly deteriorating clinically, you have to treat empirically while the workup continues. The IDS-ASC-CM guidelines support this for critically ill ICU patients.
So in those specific scenarios we treat, but how do we manage that? Do we commit to a long course?
No, ideally you treat, get cultures before starting if possible, and then you commit to reassessing daily. If cultures remain negative after 48-72 hours and the patient stabilizes, you should strongly consider narrowing or even stopping the empiric therapy. The goal shifts to targeted empiricism only when you have strong clinical or preliminary diagnostic evidence pointing towards a likely cause. For instance, if imaging strongly suggests TB, you might start anti-TB meds while awaiting final confirmation. Or if Still's disease or GCA seems highly likely and you've reasonably excluded infection, you might trial steroids after getting necessary biopsies, like a temporal artery biopsy for GCA.
That caveat about ruling out infection before starting steroids is crucial.
Absolutely paramount. Steroids can mask or worsen underlying infections, sometimes catastrophically.
What about ongoing monitoring for the patient still undiagnosed? We mentioned serial exams. What else?
It's active surveillance. Daily clinical reassessment, talk to the patient, examine them thoroughly. Repeat basic labs periodically, maybe every couple of days, paying close attention to trends in the WBC count, ESR, CRP. If the clinical picture changes significantly, repeat blood cultures. And this is where teamwork is essential. For complex FUO cases, get your consultants involved, early infectious disease, rheumatology, hematology, oncology. Bounce ideas off them. Management needs to be flexible, not rigid.
That multidisciplinary approach often helps break through diagnostic logjams. Okay, let's talk prognosis. This often helps us maintain that therapeutic restraint.
It really does. The overall prognosis for FUO, particularly the portion that remains undiagnosed even after a thorough workup, is generally quite good. Studies suggest that up to 75% of FUO cases may resolve spontaneously without a specific diagnosis ever being made. And importantly, mortality in these undiagnosed cases is low. This tells us that many FUOs are likely due to self-limited viral illnesses, atypical presentations of common infections that resolve, or perhaps inflammatory processes that burn out.
That's reassuring. But we can't ignore the other side, the potential complications, if we do miss something serious in that remaining 25% or so.
Right. The danger isn't usually the fever itself. It's the underlying condition causing it. If we miss treatable diagnoses like endocarditis, an occult abscess, lymphoma, or vasculitis, the consequences can be severe. Disease progression, permanent organ damage, even death. There's also the risk of iatrogenic harm from endless testing or inappropriate empiric treatments. It's a balance.
It really comes back to that idea we started with. The goal isn't necessarily a diagnosis at all costs. It's making sure we don't miss a treatable diagnosis.
That's the perfect summary of the philosophy. Protect the patient from the unknown disease, but also from our own diagnostic fervor.
So, wrapping up the core approach for our listeners. Managing nosocomial FUO effectively requires discipline and a systematic process. Confirm true fever first. Then, relentless, detailed serial history taking and physical exams looking for evolving clues. Follow that with a standardized baseline workup labs, cultures, paired central peripheral if lines are in, basic imaging like chest x-ray. Only then, if needed, move to clue-driven, targeted investigations using advanced tools like PT-CT judiciously to guide potential biopsies. And all along, practice strict restraint with empiric therapy, reserving it only for the clearly defined high-risk or unstable patient.
Exactly. And perhaps that leaves us with a final thought, something to chew on. We know that a large chunk of FUO cases, the ones that stay undiagnosed, have a good prognosis. So the real challenge isn't just finding any cause, but reliably identifying the patients within the FUO group who have these serious treatable conditions versus those who will likely resolve on their own. What are the best predictors? Is it an extremely high ESR, say over 120? Is it persistent tachycardia out of proportion? Specific patterns on the CBC? Profound constitutional symptoms? Refining our ability to risk stratify FUO patients early on to know who needs the aggressive workup versus watchful waiting, that's where future research needs to focus. That's the knowledge we still need to sharpen.
An excellent point and a great place to end. Focusing on not missing the treatable diagnosis while understanding the generally good prognosis of the truly undiagnosed. Thank you for that incredibly clear framework. Join us next time for another deep dive on Hospital Medicine Unplugged.